embolism. As an intensivist, let's see what is amniotic fluid embolism. Pulmonary embolism by particulate matter contained in the amniotic fluid which enter maternal circulation. Let's see, the incidence of amniotic fluid embolism is 1 to 2 per lakh deliveries. It is the fifth most common cause of maternal mortality, an ominous complication of the labor and the immediate postpartum period. This is a life-threatening, catastrophic event, but cannot be predicted. But let's see what are the risk factors. Risk factors are rapid labor, induction of labor, meconium stain liquor, multiple pregnancies, older women, cesarean section, and antepartum hemorrhage. Clinical presentation. This can present during labor, immediately postpartum, present as an abrupt onset dyspnea, cyanosis, respiratory distress like ARDS picture, and neurological impairment, which further progress to shock, coma, and finally death. If the patient survives, bleeding manifestations, we encounter with the bleeding manifestations like DIC. The triad of amniotic fluid embolism is hypotension, hypoxia, and coagulopathy. Let's say about pathophysiology. Initially, there was very different schools of thought. We thought in different way. Initially, we felt that it is related to amniotic fluid, which getting into maternal pulmonary artery, and which leads to the side effect. But right now, it failed to be more closely related to anaphylactic reaction or endotoxin mediated septic shock. Anaphylactoid syndrome of pregnancy. It leads to distributive, but also without myocardial dysfunction. What happens during delivery or immediate postpartum? There is disruption of maternal and fetal barrier during delivery. Fetal antigen enters to the maternal circulation. It leads to systemic inflammatory response syndrome like activation of pro-inflammatory and mediators, leading to hypoxia, myocardial depression, and pulmonary and CNS injury. And so later on it leads to activation of coagulation cascade and DIC. The pathophysiology is summarized in this diagram. Like we see the triad hypoxia, hypotension, and coagulopathy. So hypoxia, how the patient is getting hypoxia, the pulmonary vasculature getting obstructed, which leads to pulmonary hypertension, leading to right-sided heart failure. Later on leads to the left heart failure, which causes hypotension and shock. Second one is patient is having let's about to see why hypoxia occurs, which lead these particles obstruct the circulation and causes ventilation perfusion mismatch at alveolar level, which causes hypoxia, cyanosis, ARDS kind of picture. And third one is coagulation disorder, which is on the later part of the disease. Patients in these maternal tissue, the fetal parts are where it causes activation of coagulation cascade, which leads to decrease in fibrinogen, increase fibrin degradation products, thrombocytopenia, prolongs PTINR, which causes DIC, consumption coagulopathy, finally leading to bleeding. What are the differential diagnoses? This is an important situation. We need to rule out other diagnoses, because the diagnosis of pulmonary embolism, we need to first rule out the other causes, because it is mainly clinical diagnosis. We don't go for a diagnostic. Very hard to get. Mostly the diagnosis is postpartum. Like we have to first rule out important causes: maternal hemorrhage, Second one is patient whether having received any blood transfusion. This may be due to transfusion reaction. Third one, mostly peripartum cardiomyopathy, immediate postpartum patient getting in the failure, because the features of almost all these are similar to the features we are getting in the amniotic fluid embolism, like hypotension, hypoxia, and coagulopathy. Meaning, like not all coagulopathy we don't go in this peripartum cardiomyopathy now. Also, MI, preeclampsia, septic shock, because we know the patients are written product of conceptions are there, so which leads to puberal sepsis, uterine rupture, asthma. If the patient is asthmatic, then this may lead to asthma exacerbation and heart failure, pulmonary edema due to volume overload. How to diagnose amniotic fluid embolism? Clinical onset during labor or within 30 minutes of placental delivery. Diagnosis is mainly clinical. We first importantly need to exclude the hemorrhage as early as possible. In this, we get patient in sudden respiratory distress, cardiovascular collapse. In the absence of any other clear cause, then premonitory symptoms like restlessness, agitation, tingling, numbness we may get. About investigation, that we like routine investigation we have to do like complete blood count, chest X-ray, ABG, coagulation profile to rule out DIC, echo to rule out postpartum cardiomyopathy, demonstration of amniotic fluid content in pulmonary vasculature, like squamous cells from fetal skin, squamous cells from fetal skin or lanigo hairs from the vernix serosa. We routinely don't do it, but in postmortem examination, this is to be done. About the treatment. Treatment is multidisciplinary approach and aggressive supportive care is the key of treatment. With the things we have done, the patient is in hypoxia, for respiratory intubation and ventilation. For hypotension, we need to give inotropic support. Correct patient mostly found in a DIC, we have to correct the DIC by correcting coagulopathy. And if patient go in the cardiac arrest, or we have to follow ACLS protocol. If it happened during delivery or before, just during the immediate prepartum, we have to follow ACLS protocol. And if there is no ROSC within a 5 minute, consider immediate perimortem cesarean delivery.
Yeah. So. Is an extremely disruptive topic for an intensive care and for a gynecologist. It's a very difficult topic, very difficult problem also, very difficult problem, because you have a healthy lady who goes for labor and then almost dies, or dies for that matter. That's the problem with amniotic fluid embolism. Okay, it is something that is catastrophic for any individual, because younger the individual, more difficult the digestion of death. You understand? So it becomes very often a medico-legal problem. Very often, patient goes for labor and then has sudden episode of respiratory distress. They get intubated and then they go into DIC and then they die. So obviously they were thinking will be labor mein kuch kiya hai, ya anesthesia mein kuch hai. That's why as a clinician, you should be able to rule out the other problems that are there, and very convincingly. You understand? Because after all, as he said, there is no diagnosis. The diagnosis is clinical. So wherever you have non-clinical other clinical diagnosis, take it out quickly. For example, what are the other things that can? What is this clinical presentation? What is the clinical presentation of amniotic fluid embolism?
Hypotension, hypoxia, coagulopathy.
So this is the cardinal symptom. Hypotension, hypoxia, and coagulopathy (DIC) is the cardinal symptom. Matlab, this is what is going to occur at the end stage. Hypoxia, hypotension, and DIC. This is what is seen in, at this time. But what are the features before that comes in? Yes, so you will have breathlessness, you have chest pain, you have agitation, you have got something that looks extremely difficult, disorientation. You may have patient whose saturation is going down. Now, unfortunately, there are many diagnoses around surgery, around labor, around anesthesia, around intensive care, around that particular labor and pre-op and delivery that looks like this, which includes aspiration. Aspiration also will look like that. You understand? So there has to be mention saying that there was no incidence of aspiration. The X-ray has been done, appears to be clear. So intubation has been done, and we have actually saw there was nothing that came out from the endotracheal tube. The chances of it being silent aspiration are less likely. X-ray doesn't show any feature. What is the other thing that can present this way? Pre-eclampsia. Eclampsia can present this way, where a person gets extremely down and DIC and agitated, and things just go down for a toss. It's not eclampsia. It's not drug related. It's not drug related. Anesthesia drug related. So all these things have to be clearly said, because amniotic fluid embolism is actually a diagnosis of explosion. So if you want to diagnose it, it's what is amniotic? How does it occur in the first place? How does amniotic fluid embolism occur? You mentioned that. How?
Maternal fetal barrier disrupt.
So how does that occur? It's occur. So that means all of us should have it. Who are not me as well. But whoever is having babies should all have it, right? Whoever is having a baby should have it. This means what you are saying is maternal fetal barrier is disrupted. Placenta is anyways there, so everyone should get it. But consent not get it.
Uterine veins.
So what happens is that there is a chance for everyone to get it. That is the problem. But those people who are high risk pregnancies, for example, you've got 5 surgeries, 5 deliveries in the past, of which there have been cesarean sections in the past. Okay, they have got a deranged uterus, they've got a deranged anatomy. The cut is different. That's why we say don't go for cesarean section. No, thinking in the past was cesarean section क्यों करना है? जरूरत नहीं है, क्योंकि every time you do a cesarean section, there's going to be some kind of change in the anatomy of the uterus. Okay, and that will probably cause some kind of change. That's why we say get pregnant faster. Don't get pregnant when you're 37, 38 years old. Because the earlier you get pregnant, the more stronger your uterus is. The more stronger your anatomy is. Okay, you're not subjected to these major problems, which includes amniotic fluid embolism. That's why you don't want to be having no kid for a long period of time. Nulliparity causes this issue also. Okay, so multiple pregnancies also cause this issue. Now, since if you're looking at all these things, what you're thinking that there is something that is occurring, which is actually when he said amniotic fluid, I saw that slide in which he said go hair, this, that, all. So it's like gutter water going inside your body. When you say amniotic fluid is urine of the fetus, it is the lanigo hair of the fetus, it's the skin debris of the fetus, epithelial cell of the fetus. You understand? It's all the useless things that is there in the amniotic fluid, apart from some good things that are there. But it's equal to sewer water, no? It's equal to gutter water, isn't it? That water is actually getting into the maternal circulation. You understand? So have you seen amniotic fluid? You would have seen during your internship. It's slimy. It's slimy, It's not water. Amniotic fluid is slimy. It is. So it is that is going into the circulation mechanically. Mechanically, it is going inside. This means what is happening is the labor is markedly prolonged. When the labor is markedly prolonged, this patient is breathing like that. Okay, and when the labor market with a huge amount of pressure on the uterus. Okay, when the huge amount of pressure on the uterus, anyways, your blood, venous blood is negative. It is moving from here to the heart. God has created some mechanism in which when there is pressure that is increasing, these veins are getting compressed, and that's why it is not going inside. But something has got a derangement, some anatomical derangement, some cesarean section, something in the uterus, or the labor is so prolonged that the pressure in the amniotic fluid rises exponentially high, and this transfers into the endocervical veins or through the placenta. That is why it is seen when there is prolonged labor, and it is seen at the time of placenta that is getting removed, or just immediately post labor. You are understanding? It is not seen otherwise. It is seen either at the time of labor, just prior to that labor occurring, at the time of labor, or during labor, or immediate post labor, because that is the time they remove their placenta. There is some amount of amniotic fluid which is now transgressing inside. Right? So what would be the right way to figure out whether there is amniotic fluid or embolism? अगर तुमने intubate कर दिया, और तुम्हारा स्पूटम में स्लाइम आ गया, this is amniotic fluid. It's a mechanical transduction, mechanical movement. You understand? You have put in a tube. It has gone from here, and from the alveolar capillary barrier, it has moved into the alveolus. You have got such. So you take a bronchial lavage and send it for reporting, and you get fetal lanugo hair, you get fetal epithelial debris. It is definitely amniotic fluid embolism. You understand? Similarly, there is a protein called as THK2 protein. If that protein becomes positive, fetal protein, if that fetal protein antibody becomes positive, again that goes towards amniotic fluid embolism. Of course, this is not a test that is done on a regular basis. This is theoretical. No, nor do we do a bronchial lavage to actually figure out whether there is lanugo hair, whether there is fetal tissue. But that is what is going to be seen. If you want to ask on theory, where I want to prove this is amniotic fluid embolism, 100% proof. If you get fetal lanugo hair and fetal epithelial debris in that particular bronchial lavage, that is 100% proof that this is amniotic fluid embolism, right? Now this is one of the cases. This is one of the cases where the patient goes into a mechanical obstruction and thus cardiac arrest. Okay, what is the problem here? There is large amount of amniotic fluid in the body, inside the blood vessel. This is what has occurred now. What is happening in amniotic fluid embolism? Amniotic fluid has gone from the uterus into a blood vessel, and now in your body there is amniotic fluid, right? Of these debris, these larger debris are the ones that are going obstructing the cardiac output, which is looking like pulmonary embolism. Or this debris all over the body is wrong thing in the wrong place, that is why it is causing DIC. It is causing release of tissue thromboplastin, that is causing DIC. You understand? It is causing DIC. So this problem is what? Is this debris. So you may want to do CVVHDF. You may want to do ECMO, because ECMO will save this person's life. He's a young patient. He's not an old person. Okay, this is one place where if you initiate ECMO immediately, you are given time for this rest of the things to get better. Are you understanding? Because this is a young lady. It's not an old person who's you can just leave. So on that moment, if the patient comes with a cardiac arrest, put an ECMO and take them out for some time and let that blood then get purified by any technique that you want, either CVVHDF or plasma exchange. Do something like that, slow plasma exchange, therapeutic plasma, because anyways it's like a DIC is going to lose blood, you're giving plasma and FFP and blood from outside. It's like a plasma exchange only that will occur in these cases. Okay, but maintain the circulation for a while, because this is largely treatable if you do the ECMO first. That is why when you are intubating these patients, for example, if you want to intubate these patients, give 100% oxygen. Do not give high PEEP. Okay, do not give too much high pressures, because the more pressures, high PEEP you give, more the pulmonaries will vasoconstrict, more the hypoxia will occur. The higher PEEP you give, the more the alveolus will, pulmonaries will get vasoconstricted, and more less amount of transfer of oxygen. So let it be 100% oxygen. Give lower possible PEEP. Quickly maintain with vasodilators rather than inotropes and vasopressors. If there is a requirement of low blood pressure, give vasopressors, can't help it. But if you can give nitric oxide, nothing like it. If you can give pulmonary vasodilators, nothing like it. Go ahead and try to put in an ECMO quickly so that we can keep this patient salvaged for a while, and then body will take its own time to heal, and then let her heal properly. Okay, Golgi ke liye asan hai, put an ECMO, but in a center where there is ECMO, this is what is done. In a center where there is ECMO, we can't do it here. So in a center where there is ECMO, there, they will immediately initiate ECMO. So in a OT, what they do? Put on bypass. Cardiac surgeon is required, put on bypass, let the patient remain. Has it been done? Yes, it has been done here also. Okay, we have done that. Okay, so that way many things can be done to salvage these patients, but it is important to be very clear to the family. Your communication is the key here. So once this gets over, once this patient is in the OT is going to be transferred in a very haste. This patient will be transferred into the ICU. That is what usually will occur in these cases. And when they're coming in haste, it's important to be very open about the communication as to what it is. I don't know is not the answer. If everything is negative, it is amniotic fluid embolism. That is what you're supposed to say. And you have to say that there is nothing like this and just to explain. And to explain that, you need the theory to be right. You need the theory to be right. You need the pathophysiology to be right, to explain. Otherwise, they will not understand. Clear? Any questions on amniotic fluid embolism? There is, it's a clear mechanical problem. That's when it becomes simple to understand.
Sir, how to handle medical legal things regarding
Nothing.
this?
So you have to be very clear. It's all communication here. It's all communication. You have to be very clear that there is nothing wrong in the anesthesia. There is nothing wrong in the way we've actually treated this patient. This is a problem that occurs in individuals. Amniotic fluid embolism. That is why when you have an nulliparous patient, you have a patient with multiple pregnancies. You try to tell that this is not. There can be problems, and then pre-operative counseling or pre-labor counseling is very important. Pre-labor counseling is very important in these cases because that is why you identify the risk factors prior only. The risk factors that I told you about elderly primary, the risk factors I told you about multiple pregnancies, multiple uterine surgeries being done in the past, multiparous pregnancies. These are things that are very important in these when you're actually dealing. That's why they have extensive talks. Gynecologists usually have extensive talks with these patients about explaining about these risks. They explain about these risks. Yeah, they do that. They do that. Very few gynecologists don't explain this because this is unforeseen. This comes suddenly. You cannot predict that this patient will have it or will not have it. You cannot predict. If it comes, it comes.
So the echo findings will be similar to pulmonary?
Largely because you are having the same problems, no? You're having the same problems over there. You're going to have an RA and an RV that is going to be dilated. If you do an ECG, you will find right axis deviation. In an ECG, you might find T wave inversions in the right sided leads. You may even find an S1Q3T3 pattern. The gold standard in the diagnosis is to put in a pulmonary artery catheter and aspirate and see whether you're getting amniotic fluid. You understand? That is a gold standard. You put in a pulmonary artery catheter and then the catheter sits in is near the capillaries where the artery and vein is joining. That's what you're thinking, the wedging, where it is wedged. You aspirate from there and send that for routine examination and histopath to understand microbiology, routine smear to understand whether there is amniotic fluid. So that is the gold standard. So classically, the patients will present with a similar manifestation. Okay, they go into this, but largely you see these three cardinal symptoms. You see hypoxia, you see hypotension, and you see DIC. So quickly getting these all in place, that you have got the DIC, you have got the hypoxia, got the hypertension, you have put all this in paper. ABG shows this, hypertension was seen, the DIC picture developed quickly. All this will go towards pointers towards amniotic fluid embolism. You understand?
How do you decide not to thrombolize if you just do 2D echo patient is unstable and you see RARV dilatation and you think?
So the context, no? You're the clinician.
You just
The
have to
context.
decide based on the history.
The context is what? The context is this patient was undergoing labor, this patient was in the middle of her labor, then subacute developed it. So there's a context. So that's why as a context you're looking, no? The context of this patient is this. You understand? And that is the reason that the chances of it being amniotic fluid embolism are very high. You understand? The context is like this, and you don't get DIC when you look at pulmonary embolism. You are getting DIC also because here what is happening? The vasculature is filled with thromboblast and all kind of funny things that comes from the amniotic fluid, which is causing the release of tissue thromboblast and thus DIC, formation of DIC. You understand? So it's a very difficult phenomenon. And I have been party to a lot of expert opinions for amniotic fluid, which is very difficult to say that this is or this is not. Okay, it's a problem.
We don't need to confirmedly prove it.
You can't do it. You can't do it.
Express figure that thing.
You can't do it. Even if you want to do it, you can't do it. There is no way you can do it. You understand? Nobody does a smear and may have never seen a smear that has amniotic fluid. Nobody would have seen a smear that has had amniotic fluid. This is theoretical, putting in a swan gans and taking out the blood and sending it for. Of course, you do it and you get it. It is nothing like it. But it is. I have not seen a single patient where a bronchoalveolar lavage has been done and we have had smear positive for amniotic fluid embolism or done for that matter. It's never done only. Okay, because there's so much of this happening at that time that we don't know what to send, what to do. A lot of tensions are up. बहुत issues होते हैं, so we've never done that per se. I don't know of anyone who have done it also. I don't know, but that is the gold standard. If you actually can demonstrate amniotic fluid anywhere else than the uterus, that is actually diagnostic of amniotic fluid embolism. So that is why rule out everything else. Rule out an aspiration pneumonia. Rule out a regular pulmonary embolism. Rule out a left ventricular failure. Rule out sepsis. Rule out retained products of conception. All the other things that causes this kind of manifestation, which includes hypotension, myocardial infarction. Rule out all those things. If you rule out all those things, you are in the right place. That's how you diagnose amniotic fluid embolism. Otherwise, you cannot diagnose amniotic fluid embolism. The context is very important though. Okay? Very bad. Prognosis is really, really bad because these patients can worsen very quickly. Since they can worsen very quickly, that's why I need to. So when you say prognosis, usually when you have large number of cases, then you can talk about prognosis. But these cases are not large number. So if they're not large number, we can say the prognosis is not very good if you do not resuscitate. But if you resuscitate with the regular, what I just now explained to you, ECMO, and all these things, the prognosis. Without ECMO also there are patients who have survived. Without ECMO also there have been patients who have survived. It's not that every patient goes into a cardiac arrest or every patient goes to extreme difficult hypotension. There are patients who develop hypotension and they respond to vasopressors. There are patients who have hypotension, hypoxia, they respond to usual regular mechanical ventilation. It's not this way that every patient needs an ECMO. But if the patient goes into a cardiac arrest, this is that patient that needs an ECMO. If the patient goes to severe, more and more severe abnormalities like hypotension not responding to treatment, that patient requires an ECMO. So that's about amniotic fluid embolism.